You identify yourself for the record so that everyone out there knows who you are and what you're going to talk about for us today.
My name is Christina Mullins, and I am the Deputy Secretary for Mental Health and Substance Use Disorders at the West Virginia Department of Health and Human Resources. And today I'm going to be talking to you about West Virginia's behavioral health continuum with a special emphasis on residential care. So, as I said, my name is Christina Mullins, and I am also a two-time graduate of Marshall University, so I am sporting my green today, and I'm very pleased to be back on campus. I'm delighted to be here. Before I begin, please know that we have made every attempt to gather the most accurate information possible. But facilities and bed counts are often dynamic numbers that can and do change. Also know that I do not have all the answers, but I am committed to working together with the legislature and advocates to develop and implement solutions based on best practices. I would also like to emphasize that a continuum of care is more than just residential care, though the majority of this presentation will be spent on that topic. While investments in prevention and early intervention do not address immediate concerns of aggressive behaviors, suicidality, or other pressing concerns, they do help prevent those situations for other at-risk youth down the road. In your materials, you will find a 6-page spreadsheet that describes each of the level of care, residential care and treatment that will be discussed in this presentation. It includes a description of who pays for the service, the licensing agency, the number of facilities, the number of beds, the size of the facilities, and the code rule citations. We had hoped also to provide the annual cost today, but we did have team members out of town being trained on CCBHCs, and so we'll just have to continue to work on those numbers and try to get you an updated spreadsheet at a later date. So a full continuum of care for mental health services includes prevention, early intervention, and more intensive services. In the 1999 Olmstead decision, the U.S. Supreme Court ruled that the Americans with Disabilities Act prohibits unnecessary segregation of people with disabilities who have a right to live and receive services in the most integrated setting appropriate. Disability advocates monitor the state's Olmstead plan to assure our compliance with these requirements. It is the mission of the Olmstead plan to promote equal opportunities for people with disabilities to live, learn, work, and participate in the community of their choice through West Virginia's compliance with Title II of the ADA. And the West Virginia Department of Health and Human Resources work is guided by best practices, state and federal law, and a series of court orders, as you will learn today. So the data on this slide shows that we continue to experience challenges in the areas of mental health and substance use disorder. While I understand that the problems and challenges are what bring us here today, I also want to balance the narrative somewhat by reminding all of us that we are all working hard and have some successes. According to Mental Health America, West Virginia is in first place for meeting the treatment needs of adults. That is a shared success across policymakers, government, and providers. In addition, while any fatal overdose is one too many, national data shows that West Virginia's fatal overdoses continue to decrease. West Virginia communities have worked together with DHHR to distribute over 90,000 doses of naloxone last year. I want to pause just one more moment to describe the different population groups in the context of this presentation. When I talk about adults, I'm talking about people greater than 18 years of age without IDD. Individuals may have mood disorders, anxiety disorders, and/or other mental health disorders with delusions or even hallucinations. For children, and I know there's a little bit of overlap here, I'm talking about persons less than 21 years of age with a mental health diagnosis, and they may or may not be involved in the child welfare system. And when I talk about individuals with SUD, these are typically adults, but can include adolescents that have addiction. Treatment systems can address alcohol, marijuana, opioids, and stimulants, or any other substance that persons can become addicted to. And when I speak of individuals with developmental disabilities, I'm talking about people who have cognitive impairment, but they may also have a mental health diagnosis creating a need for mental health services. Please bear with me as I do want to highlight some additional successes before jumping into this discussion to remind us all that what we can accomplish when we work together. Many of these successes are in response to long-term projects that we started back in 2017, 2018. But again, I want us to focus on what we can accomplish. We did implement 988 in accordance with national standards last year. We have expanded mobile crisis services for children statewide. We have now 5 mobile crisis teams for adults that are in operation with more under development. We've established a step-down facility for individuals civilly committed for SUD with the goal of moving individuals into long-term recovery. And I'm really pleased to announce that particularly Sharp Hospital is using that to reduce its census numbers. We have also expanded assertive community treatment, which helps and benefits individuals with repeated hospitalizations, means that they can have their medications observed and managed to every region of the state but one, and we are hoping to have the Eastern Panhandle online this summer. Just this week, we released match data, which is survey data that will allow West Virginia community needs to be matched with health resources and provide information to support decision-making on state and local level. Over years, this will also allow us to monitor outcomes for our programs. So I also want to talk, just to kind of set the stage, about the behavioral health continuum of care in West Virginia. It refers to a range of services and support available for individuals with behavioral health conditions, from prevention and early intervention to treatment and recovery. In West Virginia, the continuum of care for behavioral health is supported by a network of public and private providers, including community mental health centers, substance abuse treatment programs, hospitals, and other healthcare providers. The state also has a system of regional behavioral health collaboratives, which coordinate and integrate services across the continuum of care to ensure that individuals receive the right level of care at the right time. I want to emphasize here that you can move back and forth between this continuum of care of early intervention and prevention and go to that more intensive level of service of residential, but you might go back later and be served by early intervention services or even prevention services. So rather than provide academic definitions of the continuum of care, I get a little bored with that stuff sometimes, so I'm gonna instead take a couple of minutes to share a few examples that come from an amalgamation of cases. I was in private practice for 3 years. I've worked with back in behavioral health for a number of years, so these are not specific individuals, but are real-world instances that we have encountered. One of the partnerships that I'm very proud of is our collaboration with the Fusion Center to conduct behavioral health assessments. The common referral that comes into our office would be from a middle school regarding aggressive behaviors or perhaps social media threats. Our staff works with the school and the prevention resource officer to identify community-based assets like expanded school mental health, school-based mental health, or other early intervention services to support the student, family, and staff. The situation continues to escalate, then we involve 988 or Help for WB, and we activate a mobile crisis team to respond to that student. The child then may be referred for more intensive community-based services called wraparound, or perhaps it is determined that the child might need residential services. But then that child, once those residential services are completed, returns to the community and those community-based supports. A second example that's very near and dear to my heart is an older one, but is of a 30-year-old woman diagnosed with schizophrenia. She has severe delusions and she was trying to parent 4 daughters. The young woman had been committed several times and was supported by a comprehensive behavioral health center in her community. Since she had been hospitalized numerous times, she was eligible for assertive community treatment to make sure that she took her medicine every day and could remain stable in her home. Due to the severity of her illness, though, the father maintained custody of the children, but she was still allowed routine visits to maintain that relationship with her children. Finally, I want to share an example of a 23-year-old pregnant female with a positive urine drug screen during her first prenatal visit. The provider is a participant of the West Virginia's Drug-Free Moms and Babies program, an outpatient SUD program for pregnant and postpartum women. Once the provider further evaluated the individual, she was referred to Project Hope here in Huntington, where she could keep her firstborn child with her while she received residential treatment services. With the help of the staff, she did so well that she was able to move into a nearby certified recovery residence and continue to participate in the Drug-Free Moms and Babies program and one of the early intervention home visiting programs. With help, she was able to deliver a healthy baby and maintain custody of both of her children. So that gives you an idea of the different levels of continuum of care and services that we strive to provide through our funding at the Department of Health and Human Resources. I cannot overemphasize the importance of prevention programs. Schools that participate in West Virginia prevention programs tend to have better outcomes. Students are more likely to perform at grade level, they have less behavioral health concerns, and they have higher graduation rates. And while not specifically mentioned on this slide, families that participate in early childhood home visitation programs are less likely to be involved in the child welfare system and have better outcomes. As I noted earlier, while the prevalence of mental illness is significant in West Virginia, we have done better than other states in helping adults and children access needed services. This slide provides examples of outpatient programs. These programs, along with crisis services, are critical because many conditions can be addressed in an outpatient setting and prevent more expensive interventions. These services are also available then as a step down when they come back out of acute care. So now we'll transition to the discussion of more intensive residential services. We know the challenges of long and sometimes inappropriate stays in our psychiatric hospitals. Due to workforce shortages and facility closures, West Virginia has lost over 100 psychiatric beds over the last several years. Currently, we have 653 licensed beds for adults and only 52 licensed beds for children. The HHR, though, has undertaken a couple of key initiatives related to our acute care facilities. Highland-Clarksburg is currently partnering with DHHR and Aetna to open what will eventually become a 24-bed children's unit, beginning with 8 beds, gradually increasing those as they expand staffing, training, and census numbers. Also, in February of this year, I began meeting with the leadership of Disability Rights of West Virginia to discuss what a path forward might look like for individuals with intellectual and developmental disabilities. Both agencies agreed that this issue deserved to have dedicated staff person empowered to look across both the residential and community-based programs. We further agreed that Bob Hansen was uniquely qualified to assist us in this process, as he has served as the state's behavioral health head of the state's behavioral health agency during the time of deinstitutionalization, was CEO of Prestera, and served as president of the Behavioral Health Providers Association. I realize that Bob Hansen is more recently known for his work as the director of the Office of Drug Control Policy, but he also has extensive experience in this area. We'll be sharing more details about how he will be working with us during the next presentation. Psychiatric residential treatment facility care is the most restrictive type of care for children. It's a secure facility and it's used for the treatment of children who have been clearly diagnosed as having a psychiatric, emotional, or behavioral disorder that is so severe that the child is a danger to himself or others. We are closely monitoring the number of available PRTF beds and hope to develop more once the additional acute care beds become available at Highland-Clarksburg. Let me preface my remarks on this slide for child residential levels 1 through 4 by saying that Deputy Secretary Chapman and Commissioner Pack are here today to answer any detailed questions you may have on child residential centers. In advance of this presentation, I spoke with a number of staff and toured actually one of the facilities. But as they are licensed and managed by the Bureau for Social Services, they are part of the mental health system that I'm less familiar with. Children served by these facilities are required to be in state custody and have a mental health diagnosis. We've done our best to accurately report the number of licensed facilities and beds. However, it is important to stress that not all beds are available due to workforce shortages. As part of my research for this presentation, I also learned that the Bureau for Social Services is working with the providers of these facility types to be able to serve children with higher levels of acuity inside those facilities in order to prevent future out-of-state placements. Crisis stabilization units are a critical part of the crisis continuum, as they provide an alternative to commitment and/or hospital stays. The crisis unit can help prevent psychiatric hospitalization, or it can serve as a step down for consumers exiting the psychiatric hospital setting. Crisis stabilization services include daily psychiatric medication reviews, group therapy, individual and group supportive counseling, education about mental illness, treatment planning, ongoing evaluation, case management, and planning treatment services to ease the transition back into the community. West Virginia has had statewide coverage for adults for many years. In approximately 2018, BBH reorganized the crisis stabilization services for individuals with IDD to one 6-bed unit. I believe there was 2 3-bed units prior to 2018 because the services were not being utilized at all. They are currently being utilized now. In 2023, we opened a second 6-bed facility to provide better geographical access, one in the southern part of the state, one more towards the central north. Assessments of existing patients within the psychiatric hospitals will determine whether these programs might be best to address stepping individuals down from hospitalization or preventing hospitalization entirely. Additional crisis stabilization units are a top recommendation by the advocate community for individuals with intellectual and developmental disabilities. As of right now, we still have capacity in the 2 existing units for additional clients. We will closely monitor that capacity as we move through the process. If we find that additional beds are needed, the Bureau for Behavioral Health will need additional resources to support those services, as they cost about $700,000 per year to operate, because Medicaid simply does not cover all the ins and outs of all those services. I strongly believe that crisis beds are critical to the continuum of care for all people. However, they will not be able to meet 100% of the needs by themselves and on their own. Oh, before I go forward, I also want to point out that we do have 1 children's crisis stabilization unit under development. We have a meeting with the architectural firm tomorrow so that I can provide better timelines and updates on that in the future. So intermediate care facilities are for individuals with intellectual disabilities. They're a little bit more intensive. They're not at an acute hospital level, but they're more than a typical waiver home. We are aware that there are a small number of individuals that are difficult to serve in this setting due to co-occurring mental health conditions and aggressive behaviors. This has raised the discussion about whether another level of care or more crisis stabilization units may be needed to serve these individuals outside of the psychiatric hospitals. First, I think we need to make sure we are maximizing the use of the existing continuum of care. But I think we may find we may need more of something, whether that is additional crisis beds or something else that we don't know yet. It is always labor intensive and often costly to modify or accommodate more challenging behaviors within a community-based setting. However, we have found that when you bring a group of people together and ask what they need to make it work, solutions can often be identified. The challenge in these situations is cost, as it usually requires special staffing ratios or other accommodations not covered by Medicaid. So, group residential care. This level of care is usually known as group homes. In West Virginia, we have several types of these homes. The first that I want to talk about are funded with state dollars. They are not funded by Medicaid, and they are group homes for people with severe mental illness, and these group homes were established by Hartley court orders. A second type of group home serves individuals with developmental disabilities. These homes tend to be smaller and are often in a regular house like you or I might live in. They are located and dispersed in communities throughout the state. At this time, there are 677 of those homes. This number includes licensed and unlicensed homes. Any home with 4 or more beds must be licensed. Any home that is owned or leased by an agency must also be licensed regardless of the number of beds. So if it's a 2-bedroom home or a 1-bedroom home owned by an agency, it has to be licensed. Here's a little bit of our tricky widget though. We'd love to be able to tell you how many beds are available, but we are unable to break down the numbers for licensed versus unlicensed homes right now. OFLAC does not distinguish waiver licensed homes from other types of homes like the mental health homes referenced on this slide with a behavioral health license. So we are currently working with KeyPro to track this data down independently from OFLAC. So a little bit about forensic group homes. They've garnered quite a bit of media attention in recent months. The first forensic group home opened in about 2006. There's some debate about 2003 versus 2006, but somewhere in there. And the most recent home was opened in 2022. Homes were initially developed as part of a Hartley consent order. The expansion of new homes is guided by the forensic wait list, which was at 17 persons last week. Forensic mental health patients eligible for community placement have been charged with a crime but have either been unable to stand trial or found not guilty due to mental illness. Patients must go through a very, very, very intensive process to be eligible for community placement. This process is guided by state code and must be signed off on by a judge. If an individual violates any part of the agreement, they must return to the hospital. Providers report that because of the stringent processes, these homes are easier to manage than other types of group homes. None of the residents in these homes have reoffended, and none have returned to the hospital for more than a medication adjustment. So a little bit about our substance use disorder treatment facilities. In 2017, West Virginia had 197 residential treatment beds. Ryan Brown funds established in 2017 by House Bill 2428 enabled expansion of treatment beds. West Virginia now has 1,581 beds approved by Medicaid. There are some additional beds just for transparency's sake on the OFLAC website that do not bill Medicaid. There are not very many of those, and we're working to reconcile that, especially given House Bill 3337 that limits the number of treatment beds to 250 in a given county. At this time, there is only one county, and that is Wood County, that has exceeded the 250 bed threshold set in 2023 by House Bill 3337. EHHR explored adding residential treatment for adolescents. We have put out 2 funding announcements for adolescent treatment. We have not received a single timely application for adolescent treatment opportunities. Workforce shortages are cited and insufficient startup funds. And I'll talk a little bit more about that in a minute. A little bit about our ASAM levels of care. 3.7 is your highest level. It can be done in a community-based setting or a hospital setting. Usually you may think of it more as detox. That's the typical framing for that. Individuals are then usually stepped down to 3.5, which still requires a high number of clinical hours, and then step down to 3.3 or 3.1. 3.3 level facilities are for special populations. For example, like with individuals with intellectual and developmental disabilities. So that's why you see that we only have one of those with 8 beds. But it did provide the number of each of the levels of care that we have and the licensed number of beds. 3.5 tends to be pretty popular, as does 3.1. Those tend to be provide a good level of continuum of care. So once someone exits a residential treatment facility or completes a program at a residential treatment facility, they may go to a recovery home, or also known as a sober living house. I really want to emphasize that residential treatment facilities are different from recovery homes or sober living houses. Residential treatment is licensed by OFLAC. Recovery homes are certified by WBAR. They're not licensed. While DHHR does not currently fund expansion of recovery homes, it should be noted that there are certain areas of the state that do not have adequate access to certified recovery homes. That is creating some challenges for our Department of Corrections because they don't have certified recovery homes to refer people to. And the Eastern Panhandle in particular is experiencing that challenge, though there are other communities as well. So there is a typo on this slide. I think that there might be a ghost living in my computer because I've corrected it 3 times. The counselors are actually currently available are 1,115, not 115. I'm going to figure out why that keeps changing on my computer, but I don't know. But workforce shortages, I really have to talk about them because they're so pervasive at every level of care, from direct care staff and group homes to psychiatry services. We do not have enough of any single workforce type. My continuous question to my team is why? Why? Shortages are happening across all employment types. Agencies with higher rates of pay are also struggling with this issue. So it tells me that the problem is bigger than just pay and reimbursement rates. Though that's always a consideration. The agencies that pay less are struggling more. Decreasing college enrollment, I'm also worried about that because it has the potential to further exacerbate this issue. And we're starting to hear a lot about that. But when you look particularly at counselors and psychologists, where is that workforce going to come from if we're also seeing decreasing college enrollment at the same time? So addressing these issues is likely going to take an all-hands-on-deck approach across multiple sectors of government and industry. It's going to take the folks working in this room working together with different state agencies. We need to increase workforce participation rates and market mental health careers in a positive way. These careers should also carry wages commensurate with their training and education. I wanted to spend a little more time on this issue because it is happening in every single state and will impact the service gaps that I'm going to talk about on the next 2 slides. So for me, this is kind of the meat and potatoes of what I wanted to present today, but I felt like I needed to go through a lot of background to get here. I am providing you a list of prioritized service gaps that we are seeing from DHHR. I talked about the fact that we have children's mobile crisis access statewide, but right now we only have 5 mobile crisis teams for adults. Expansion is underway, but startup costs are a challenge, and workforce shortages are really hurting our efforts. However, if things go well and we get our state plan amendment approved and everything goes as we hope it will, we hope to be able to have those expanded statewide by January of 2024. Also, I cannot emphasize enough the importance of our assertive community treatment teams. These people literally are on the ground watching people at high risk for hospitalization take their medications. They're with them doing med passes. If we haven't made contact with them in a few days, they're going out and making that contact, helping make sure their rent's paid. people who participate in these programs are dramatically less likely to be hospitalized. Again, we have been working, as I'm sure everyone in this room knows, the Eastern Panhandle has some unique challenges, and we are this close. We are so close to having an ACT team for the Eastern Panhandle. We hope will be operational by July of 2023. It's my understanding that they are in the process of hiring a program director for that program. And once they have that person onboarded and trained, we'll be able to start launching services for that area. You heard me talk a little bit earlier about acute care beds for children. We only have 52 right now. We have kids stuck in emergency rooms that we need to be able to move into more appropriate residential treatment. So we have been working with Highland Clarksburg to reopen their children's unit. Aetna has made an investment at that facility, and we are looking at how we can help with their workforce development and startup costs. And if all goes well, we will see some of those first beds start to open in August of 2023. The department is also working on crisis stabilization beds for children. We have announced ongoing that we are developing a unit in Elkins, West Virginia. We have a meeting with the architectural company tomorrow. We have identified a potential provider for this unit, but workforce shortages are our primary concern. We are going to need a children's psychiatrist to be able to really help us get this off the ground and make it work, and experienced child psychologists and therapists. Another service gap is lack of placement for individuals with IDD and mental health diagnoses. Our plan, and we'll talk more about that in a minute, is to assess mental hygiene petitions on individuals with IDD, assess the current status of those placed, and specifically define the population needs. We know we have a problem, but what's the specific problem that we're dealing with that we don't have the resources right now to solve? The challenges for this are workforce, lack of community-based services, and I really need to put this out there to you, is that we don't have funding sometimes for non-waiver eligible clients. So you get an individual with a diagnosis of IDD, but they're a little bit higher functioning than what the waiver allows, so they fall into a funding gap. And that's a challenge for us because we don't necessarily have a payment mechanism to move them along. We are hoping to be able to make very specific recommendations by December of 2023, and you do have a detailed work plan for the next presentation. We'll go into that a little more. We also want to provide professional support for staff working with individuals with developmental disabilities. So we've reached out to the WVU Centers for Excellence in Disabilities, and because other states are doing what's called a Project ECHO. So they're getting expert providers together, and then service providers can say, I have this really tough case. And we can bring that really tough case to this group of expert providers, and we can do troubleshooting, brainstorming, and hopefully avoid a hospitalization. WVU has done the research with several other states. They think this was actually within their scope of work. So they're not even going to charge us extra for it, and we hope to get this off the ground in July of 2023. Forensic group homes is another service gap that we're going to be monitoring. We will be waiting on the legislative rules to be promulgated to assess the next steps for that. We also want to be watching the forensic group home wait list while we go through the legislative rulemaking process. And frankly, we need to do better community education as we're working on our way through this, and funding is going to be a challenge. And so this, we have a time frame on as March 2024, just because that's when we would expect to know what those rules are going to look like. Adolescent SUD treatment, we got a call this week, even for a 17-year-old in need of treatment. We have put out, again, 2 funding announcements for this population. So we're kind of stepping back for a second and looking at barriers and potential next steps. We know that workforce shortages, particularly for children's services, are driving this problem, as well as insufficient startup funds. So we'll be meeting internally and trying to formulate a plan or a new plan for this by July 2023. We will not have this problem solved that quickly, but we do want to at least have our next steps defined by then. And that concludes my prepared remarks. So
I think we'll hold questions since Christina Mullins is the presenter for the next section as well, along with Bob Hansen. They're going to talk to us about DHHR's plan for IDD patients at Sharp and Bateman hospitals. So we'll let them do that presentation and then we'll open it up for questions.
So I'm going to make some opening remarks and then I'm going to call Mr. Hansen up. Intellectual disability involves impairments of general mental abilities that impact adaptive functioning in 3 domains or areas. These domains determine how well an individual copes with everyday tasks. I think that historically we've always talked about IQ tests and the mode of thinking around intellectual disabilities is changing to talk about deficits in domains. So the conceptual domain includes skills in language, reading, writing, math, reasoning, knowledge, and memory. So there's deficits in those areas, but as well as deficits in social skills. When we say that, we're referring to empathy, social judgment, interpersonal communication skills, the ability to make and retain friendships in similar capacities. The practical domains center on self-management in areas such as personal care, job responsibilities, money management, recreation, and organizing school and work tasks. So when you start seeing deficits across all of those domains, usually also combined with a lower IQ result, then we start to see that diagnosis emerge on a continuum, usually from mild, moderate, severe, and more profound functioning. It should also be noted, though, that it is not uncommon for individuals with intellectual disabilities to have a mental health condition such as ADHD, depressive and bipolar disorders, and anxiety disorders. Individuals with intellectual disabilities may also exhibit aggression and disruptive behaviors, particularly if the disability is more severe. So the more severe the disability, the more difficulty they're going to have communicating, and they're going to act out. Historically, my role in working with individuals with developmental disabilities has been tied to public health. In working with children with special health care needs, that's where I first became involved in working with the advocates, and it was around kids. But when I became commissioner of the Bureau for Behavioral Health, my involvement shifted to supporting families, employment issues, and as a funder for the crisis stabilization units for individuals with IDD. You should also know that the Bureau for Behavioral Health has only 2 staff persons assigned to IDD issues to support the work that we are charged to do as part of our federal block grant programming. This is by far the smallest team that we have in the Bureau for Behavioral Health. So when I transitioned to the role of Deputy Secretary, Interim Secretary Coben asked me to represent him in meetings with the advocates so that we could begin working on these very issues that we're here to talk about today. At the same time, DRWV reached out to Bob Hansen as a trusted source to help mediate these discussions. Both agencies, we were in complete agreement that Bob would be able to help us move the planning process forward and began meeting every 2 weeks starting in February of 2023. We agreed very quickly that the initial focus of our work should be reviewing the status of patients with IDD in the state psychiatric hospitals. We want to understand why their discharge plans cannot be implemented and see if knowledgeable staff with strong relationships in the provider community might be able to expedite community placements for some without the addition of new community services. Given the small number of existing staff, Mr. Hansen agreed to help us as a part-time contractor. Second, we want to work with the hospitals to understand their current programming and what works. I am hearing really good things about Bateman STARS program, and for any of you planning to tour that facility, that program is getting a really positive attention, and they are more frequently able to discharge persons with IDD from this unit. We need to understand the key components of this program and determine if it can be replicated in the other facilities. We may also learn about additional programs like the Planned ECHO project that I mentioned earlier that can help our efforts as we work through this process. Finally, we want to review the commitment papers. I think that those commitment paperwork is very telling for each person with IDD, regardless of whether or not they were committed. This will help us identify common themes, specific service gaps, and make clear recommendations for enhancements to the spectrum or to the continuum of care. Our plans are outlined in the work plan that should be in your packet. It looks like this. DHHR is committed to continuing this work and making recommendations for all of us to consider. And now I'd like to give Mr. Hansen the opportunity to share his vision for this project.
Good afternoon.
Mr. Hansen, it's customary that we swear in our witnesses once during the interim session, so do you swear to tell the truth, the whole truth, and nothing but the truth, so help you God?
I do.
Okay, please state your name.
I'm Robert Hansen, and I'm Special Assistant to work on IDDs.
Thank you very much. Please present.
Well, thank you. I just started working part-time last week, but I want to tell you a little bit about the processes that I plan to go through so that I can address this issue on behalf of DHHR. The first thing that I'm going to be doing really is getting a good understanding of the problem instead of jumping into solutions. So what I intend to do is become very active in visiting both hospitals. I've already been to Bateman Hospital, and I'm going to Sharp next week. I want to meet individually with each patient who has an IDD and who has been civilly committed to the state hospitals. I want to learn about what their disabilities are, what their challenges are, and what the discharge plans are for each individual. The other thing I want to do is continue meeting with the advocates. That is Christina has said, is already begun, and I want to meet with individual advocates so I understand their perspective completely on how best to serve these individuals who are in our two state hospitals. Then I also plan to meet with providers, not only collectively, but I would like to get out and meet with providers and tour programs and listen to and observe what type of programming is going on in our community so I have a better understanding. I also need to be, and I already have met with the staff within the waiver program within BMS and BBH and KeyPro so that I understand from the state perspective what is going on. Then further, I intend to meet with the Autism Training Center, which is here, with the Center for Excellence in Disabilities at WVU, and with the Developmental Disabilities Planning Council. So I really want to learn about this issue as much as I can. At the same time, meeting each of the patients and working actively with state hospital staff and with community staff to begin in facilitating a more accelerated discharge planning process. So my three goals in working will be these things. One is facilitating a better discharge planning process for individuals with IDD that are already in our state hospital. Two is working within both hospitals to ensure that these individuals are receiving adequate programming that are going to help prepare them for return to the community. And then third is develop recommendations of what we can do to prevent further commitments or reduce the number of commitments in the future. So I intend to do that and work on these issues, and it's part of the detailed work plan that I think is in your packet, and I'm looking forward to this. I think this is a challenge. I think There are going to be many barriers and problems to overcome, but also I feel that there will be success. The last thing I'd like to do too in my plan is to work and learn about what else is going on around the country. You know, are there better solutions to serve individuals that have challenging behaviors and also have intellectual and developmental disabilities? So I plan to do that. Then lastly is if there are commitments of people with IDD from this day forward, I would like to be involved almost immediately as soon as possible so I can understand the circumstances that led to that commitment process and why it happened. So I'm looking forward to working within DHHR and working with the providers, working with consumers, family members to address this issue.
Thank you very much. Just one comment. I see December 2023, you plan on making recommendations. So just plan on coming back to see us December, January, so we can hear what those are as well. Are there questions from the committee? Delegate Griffin.
Yes.
And your microphones are on at all times, so.
Thank you, Madam Chair. I guess, Christina, my question was, I think you said that, and I guess it's referring to the psych hospitals, that we've lost 1,000 beds.
Lost over 100.
100, okay.
It's about 140, but it's over 100, and I think it's about 140.
Is that primarily due to the Olmsted plan, or is that just inadequate?
So it's places like the facility in Wheeling in the north that closed, the hospital that closed up there. It's a process of shutting down beds due to cost. It's just been a lot of closures and a lot of it being driven by, well, in that case, really old building and then workforce shortages.
Is there a plan to remedy that in any way? Is there any suggestions in that regard?
So we are evaluating working with Highland. We're prioritizing the children's beds first because they are so low. We, in response to the one closure in Wheeling, we were able to open a few beds, I think, at Reynolds Memorial. We are having conversations with various hospitals to see what they may be able to do. But I want to be very transparent. When we go to a lot of these agencies right now, the workforce shortages, they're just kind of looking at us and saying it's going to be really hard to do because we don't know how we can hire and staff it.
How are these patients being handled that are not getting into a bed? I mean, is that...
So we have some children that are being boarded in emergency rooms. We have people who are, I would like to believe, though I don't know that to be true, 100% true, that we're serving some people in crisis stabilization units. Our census numbers sometimes run a little high at the state hospitals. Other things that we're trying to do is work on, for example, the step-down unit for people with SUD, substance use disorder, so that if, once they're stabilized, we can transfer them to that lower level of care. So we've got about a 24-bed facility, plus or minus a couple beds. I never remember if it's 22, 24, 26. So around that area where we've opened that up that's specific for step down there. So we're trying to also look at creative opportunities to bring the bed numbers, to bring the census numbers down so that we can serve the individuals who need them most.
Thank you.
Further questions of the committee? Delegate Talmadge.
Yeah, several. So right now, because we lack some of the beds, particularly in the acute care facilities, what is the cost of diversion to divert from our state facilities to some of the, say, Highland or some of those sorts of things? What is that costing our state?
I don't know what the total cost is off the top of my head, but it's about $850 to divert to another facility like River Park or Highland.
Why has West Virginia not been able to develop community-based services for individuals with IDD in the past? Do you have any insight to that? Is it?
Excuse me, Delegate Tully, I just want to interrupt for 1 minute. There is a tour leaving for Lily's Place if anyone needs to go to that. They're holding the bus for a few minutes. Otherwise, we'll just continue here. Sorry.
That's okay.
Delegate Tully, can you ask me that question again?
I can. In the past, we've had difficulty with developing some community-based services for those with IDD. And do you have any insight to why that has been historically the case here in the state?
I think we've done a really nice job of expanding waiver homes, and trying to place individuals in the least restrictive setting possible. If you're looking at the intermediate care facility slide, there is currently a moratorium on the development of those. So there cannot be additional development of those. But there are a number of waiver homes for individuals with lower acuity levels.
And you mentioned the substance abuse recovery. The state pays for 28 to 30 day programs, correct? Does it pay for anything greater than a 30-day program?
So the state pays for residential treatment programs. You can start at a level 3.7, typically 5 to 7 days, depending on what your acuity level. But then you can step down to a 3.5 level of care and perhaps get another 15 days. And then if you still need it, you can step down to a 3.1. So that range of services, in theory, can go to from about 30 to 45 days, depending on the severity of services. One of the things that we really need to double down and work on, though, is connecting, making sure that our residential treatment facilities are doing strong connections back to those outpatient therapy programs in our at the comprehensive mental health centers. Some of our residential treatment programs even have outpatient programs embedded there, so they can even stay with the same agency, but really wanting to hold on to people through that continuum of care so that they step down and we don't lose them to those services.
So about 45 days is really the average for the inpatient.
I don't know if that's the average, but that's kind of
roughly
the
range.
30 to 45, I'd say it was probably.
With the crisis stabilization units, what is the average length of stay for adults, adults with IDD and children? Do you have any idea? Could you ever prognostice? I know the children, that's under development for the children in the state of other states. What would be the average length of stay or the goal length of stay with those?
So the crisis stabilization unit that we're working with out in another state for kids, they're just now trying to get open. So I don't know if we have a good number for kids. I can tell you that for adults, it's about 4 days. Or not, for adults, it's about 4 days. And for the IDD population, it's closer to 30. They take a little longer because you got to spend more time connecting them to community resources. And I think we also spend some extra time making sure that they're medically stable.
And you mentioned that certain parts of crisis stabilization isn't funded or isn't compensated or isn't reimbursed. Can you tell me more about what is or isn't reimbursed in that particular realm of care?
I think I'm going to have to get back to you on that. I don't want to misspeak.
And that may be a better question for Commissioner B. Quite honestly, I just thought maybe you might know. I do have a couple of questions. The facility in Elkins, how many beds are you planning on for that facility?
I don't know that we've made a final decision yet. We've been working with the Hospital Association and other groups. I think the number 12 is floated around, but I think that we have not settled for sure on a number. But we're going to be working with. We have a work group together with working with the Hospital Association. We have an internal work group. We're also working with the group that's a little bit further ahead of us out of state. So we're trying to get as much input as possible to see what's kind of the ideal for that, for cost benefit analysis, but also for the treatment of the kids.
And you mentioned, so the forensic group homes on your slide, I see adults and adults with IDD, and I see nothing mentioned about children. So we don't offer those types of services within the state. Would you see that that would be a need? Because I hear from some people that work in the justice system and in the court system and probation that may be something that we would like, that they really think.
We don't offer group homes for kids, but we do have forensic programming for youth. And our the unit at the state at Sharp helps us coordinate those services for kids.
How closely do some of the programs work with, say, your justice system, your family treatment courts, your drug abuse court, your substance abuse courts, your day reporting centers to get placement or treatment for co-occurring like mental health disorders? Do you have any relationships with some of those? You know, any programs that work within their court system to deliver a comprehensive model of care?
I think that we've been funding family drug courts. We have family treatment courts as well. Probably not the best expert to really go into the detail on that, but I do know that we are funding those programs and that they're available in many of our communities.
One of the things I think I see as a problem is that it seems like, you know, things work in silos. So the court system's here, the behavioral health system delivery is here, but there are so many overlapping facets. I think that really probably need some more integration of those two systems to work well for for patients. And my last question, I swear I'll leave you alone. You mentioned that on some of this is on your slide 18, and it's talking about individuals with IDD and some of the waiver. And you mentioned that sometimes someone can be a little higher functioning and not qualify for the waiver. Have you ever who makes the determination of who is eligible for the waiver? Is that done through the Bureau of Medicaid Services, BMS?
That Bureau for Medical Services coordinates that.
So they coordinate that. Have we ever had, do you know if it's ever been examined, if we've had someone who has ended up back in the hospital and maybe has to have more intensive treatment and then they come back out into the community? Have we looked at adding that into some of the criteria that may bump them up to qualify for a waiver, say that because you're being proactive and you're trying to prevent another hospitalization from occurring? We know they've had one, they've had to go back. So now are we going to prevent the second one, the second hospitalization, or third or fourth or whatever?
I hear what you're saying, and I don't know if we've looked at changing the criteria or not. What I do know is every time that someone with IDD is admitted into the state hospital, we rigorously evaluate whether or not they can become eligible for waiver, because that's going to give them the best access to resources.
You mentioned, you know, the aggressive community, you know, support systems that they would need. And I just wonder if that would be an option, that we could maybe bump them up on some point values or assign some higher values because they've already had one regression to prevent further.
They would certainly be eligible for assertive community treatment. And I had a similar thought as you and want to dig into that data a little more.
And I wonder how much the cost, I mean, I think that there may be a cost savings there to the state if you can actually, you know, an ounce of prevention is worth a pound of cure. So I think maybe that might be something we need to work on and work with Commissioner B. Thank you.
Delegate Fairbacher.
Thank you, Madam Chairman. And thank you, Deputy Secretary and Mr. Hanson. Deputy Secretary, on your slide 16, you talked about the cross-cutting challenges, and you talked the very first bullet point, only 13% of the state's behavioral health need is met. How does that compare with other states or nationally? Are we an anomaly? No.
We're not an anomaly, but we're not rated as high on that particular indicator and there is some conflicting data. So you have the HRSA data that says that only 13% of the state's needs are met. But at the same time, when you look at the Mental Health America report, we're doing better at getting adults access to care. But this problem is a nationwide problem. And I think that we struggle more with provider shortages than other states do, but we are all struggling with those provider shortages.
And that a great lead into my next question, which is on the next two slides, your prioritized service gaps, 3/4 of them talk about workforce shortages. So have you thought about, are there states where those shortages are not an issue that we can learn or steal shamelessly, or how do we address that? Because it seems like they're very intertwined, and without addressing that, our intentions may be and plans may be wonderful, but without the staffing required, we fail.
So that's a place where I really struggle because I feel very frustrated because we have great ideas. We have Medicaid policies that enable us to expand certain services, but without the workforce, we don't have easy answers for it. I can tell you that I meet with other Region 3 directors every month, and we are all struggling with that same issue. But we are, a contingency of us is going to attend the National Association of State Mental Health Program Directors meeting in July, and I am really hoping that there will be some sessions on workforce where maybe people are starting to make cracks or crevices or innovative ideas, whether it's ways of using telehealth more or differently, and telehealth isn't the end all be all, especially for some of the services we're talking about in a crisis stabilization unit. We physically need people there. But how might we use them as workforce extenders? But this is on my mind. I mean, it is going to take, it's not just, and we're putting out loan repayment programs, we're doing all of these things, but if the workforce is not there, if people are not participating in the workforce, so I'm wondering if we need to start thinking about some of the other state agencies that work on workforce participation and partnering with them to address some of the core issues of the problem.
I just see that as being a common theme that we have to address, that the other plans, and so perhaps, Chairman Summers has already kind of talked about the December timeline and coming back, but thoughts and ideas, particularly if you're going to be getting perhaps some insights that we could leverage from that reference July meeting, bring those back so we can have those on our radar screen for your support and help. Thank you.
Senator Plummer.
Thank you. First of all, I want to make a statement that I agree that the workforce, in my estimation, is our #1 issue, whether we're talking about healthcare, education, or anything that we're doing. The state has done a lot to attract jobs, but we're not fulfilling the qualifications of the people, so we really got to be in tandem on that. Let me sort of shift it to the forensic group homes. As you're aware, in this county, we had something that came up during the session. What are you going to do to inform people that are elected in those areas, not only legislators, but also the county officials, so they know a little bit more in terms of what's happening in the future?
What I will say is we've learned a lot from this experience. And I think from now on, we will be working to, first, Mayor Joyce has been really good and offered to sit down with us and offer some really concrete recommendations for how we can do a better job in the future. But we are also now talking about, we need to be meeting with delegates, senators, mayors, county commissioners, and letting folks know that this is under consideration before we sign on the dotted line, so to speak. And educating and asking them, how is the best way to educate your community and to share what these services are in your community, particularly around the forensic group homes. There were some misunderstandings, and we could have done a better job on the front end. And we've learned a huge lesson, and the Parkersburg community has really done a great job in working with us and sitting down and sharing their concerns and saying, we're frustrated, but here's how this feels, and here's how you can help us. And we want to continue to learn from that experience and do a better job.
So as a follow-up to that, then as we move forward, When you look at it, they do not want them in residential areas, and the community has said that to us. If you were meeting with the county commissioners and the legislators and others, we could maybe identify some areas where they would be more isolated and have some more protections. So that's the type of thing that you're going to be looking at.
Yes,
Okay.
is looking to you guys for that help and support, because we will need those types of services available in communities, but working with you to say also, you know, they have to be in areas too where we can staff them. And we have a group home, one group home in a very remote area that has teeter-tottered at least once in my tenure of closing because we couldn't recruit to that very rural area. So looking to you guys to help us do that balancing act so that we do a better job, and also educating communities so that they understand that it really is a 14-step process to be in a forensic group home, and we want, and that, you know, what it really is.
Well, let me say this. In my 31 years of service in the legislature, this was the most surprised and caught off guard I was on any issue. And it was embarrassing.
And I would like to say that I regret that happened.
Thank you.
Other questions? Yeah, Delegate Height.
Thank you, Madam Chair. Secretary, I hate to beat a dead horse, but I also want to talk about the workforce shortages. And you stated earlier that you didn't think it was all about pay or reimbursement rates, but that leads me to believe it's at least a little bit about pay and reimbursement rates. So how much of that is about pay and reimbursement rates, and what are you looking into doing to correct that?
So one of our projects that I think I talked with you guys about last week, it's a long-term plan, is that move towards those certified community behavioral health clinics, because that does improve quality of care. We don't want to just raise reimbursement rates across the board. We want to provide high quality care in communities at a certain level that empowers and enables, and those clinics deserve to get those better reimbursement rates, right? And that improves parity with mental health or physical health as well, because that puts us in that realm of paying federally qualified health centers and mental health centers more similarly. So that's a long-term, part of the long-term plan. We have to continue to work with our payers to try to advocate for enhanced rates, and looking across as best we can to advocate for payment plans that don't break the state's budget, but also enable these facilities to be able to hire and do good business. So I think we're going to have to constantly be evaluating rates and return on investment. And I think that that's kind of where we probably are going to end up, is if you're doing a good job, then paying for performance is probably where we're gonna have to look to go.
There seems to be a crisis for the direct care workers in particular, and has been for some time. There's some corrective action taken where there was a bunch of money infused into direct care workers for a couple of years in a row, but that's about to run out. So is that going to be an area where there's going to be a focus in those particular workers?
I think we're going to have to keep talking about it. That's something that is happening on the Bureau for Medical Services side of the agency, so I don't want to step too far out of my lane. But that is definitely a concern that we're going to have to keep working on.
With 5 minutes to go, I will send my questions to you in an email. So you won't have to endure that. But I would like to say that as a committee, we're very pleased that you brought on someone to assist with the IDD issues that we're having in the state, because we are reached out to on that issue a lot. And you know, we also had a bill last session where we talked about an intermediate type facility. So if a person wasn't in a psych hospital and the 4 to 8 bed unit wasn't working, was that something that we needed to contemplate in our state? So as Mr. Hansen looks at those issues, if he identifies that as a gap, we would want to know that. But any other business to come before the committee? I have two things. One, I need the committee members to email John if June 12th works for you for availability to tour Sharp Hospital. And our tour of Bateman Hospital starts at 2 o'clock tomorrow the bus will be outside of the center. So I hope that you can all attend that as the Oversight Committee. I think it's important that we evaluate these two psych hospitals. So, all right, chair looks to the co-chair.
Madam Chairman, I move we adjourn.
Co-chair moves we adjourn. All in favor say aye.
Aye.
All opposed no. The ayes have it. We are adjourned. Thank you very much.